Hi, in today's episode, we're going to talk about if you can take estrogen in perimenopause. I'm Dr. Valerie Davidson from Progress Your Health.
And I'm Dr. Mackey from Progress Your Health. So today we have a question from Jackie, and she has some concerns about starting estrogen, but there's a little twist to this one that I don't think she really quite understands. So why don't you read the question from Jackie?
Which is probably why she's asking the question.
Yeah.
So no, this is a good one. Here it is. So I am concerned that if I use estrogen cream such as Estriol, that I will gain weight and lose hair. I have seen conflicting accounts to whether this is true, and some say that it helps to regrow hair and helps with weight loss. I have not started menopause yet. I'm almost 40, and I want something to help me stay youthful, lose weight, grow my hair, which has started thinning very badly and continues since pregnancy, help protect bone density, improve mood and memory, and get my libido back. Is estrogen cream a good thing for me? Thank you.
Well, there's a lot to unpack there. She's asking all the right questions, sort of. The concerns about, weight gain, hair loss, those are obviously perimenopausal, menopausal symptoms. But there's a big clue there in her question that sort of kind of gives us an answer. It's not whether she can take it or not, or it's not whether she's going to have any side effects, the hair loss or the weight loss or not. There's something very specific in the question.
And what's that clue?
Well, she says she's almost 40, so technically she's 39, wondering if she wants to be able to use estrogen or not. Estrogen as a systemic treatment, she's not really a candidate for that quite yet, because we are assuming, based on just age alone, that she still is having a period.
And, and what she's talking about here is very true, because there is so much, conflicting conflicting opinions out there about whether you can take estrogen in perimenopause, whether you can take it in menopause, different side effects, how to take it. In fact, I love to do a little bit of Google searching, and now with AI actually has some generated answers saying that you can take estrogen when you're in perimenopause. And really, that is not I wouldn't say that's not true, but I'm really hesitant in women that are in perimenopause to give them estrogen therapy because of the side effects, because of the risks. I love bioidentical hormones. I love hormone replacement. I think it's amazing. It can do so many things to help with so many symptoms and quality of life and longevity. But at the same time, you want to be really careful giving a woman that's already making estrogen more estrogen on top of that.
Yeah. So the standard answer, the quick 2-second, this is less than a 3-minute video answer, is that she's not a candidate for estrogen. Because of her age, because by giving her estrogen, she's just going to throw off her cycle. She's going to probably have more bleeding, heavier bleeding. She's technically just not a candidate. However, she mentions estriol cream in her question. Mm-hmm. So that's one caveat where you could say she is potentially a candidate, because you mentioned on a couple of podcasts ago that you've been using estriol yourself since what? You're in your early or mid 30s?
Well, I've been using estriol topically on the face, since probably my mid to late 30s, and I'm 51 now. And I do think just for targeting the skin on the face, it is really good for helping to build collagen and helping with fine lines and wrinkles. And so I do feel in that respect, but that's where it also comes down to dosing too. You have a certain dose, so you know that it doesn't go into the bloodstream to affect systemically. So I do have some women on a little bit of estriol, kind of more systemically, trying to work on that when being in perimenopause, but we always look at the blood levels and checking the blood levels. I would say, estriol is so much more gentle that could be a component that Jackie could use, or another female that's in perimenopause, but certainly estradiol, so estradiol is E2, that's the strongest form of estrogen that we make in our bodies, is giving Jackie or somebody like Jackie some estradiol. I think she would probably gain weight, because estrogen can, if you're having too much estrogen in your system, Jackie obviously is, she's young, she's 39, she's just got over pregnancy, so she was cycling, that she is making estrogen. You put more estradiol on that, she could gain weight, because that causes a lot of water weight, can make you moody, that can throw off a lot of skin issues, even some sleep issues. So I would say for Jackie doing the estradiol, that would probably be a no.
Yeah. I think it would probably, honestly, I probably don't think it would. She might feel great for a while. And then I think we just talked about this on the last episode or a couple episodes ago, that I would eventually catch up with her, and her cycle would just sort of dictate that she just can't maintain it.
Yeah, the estradiol loves to thicken the endometrial lining of the uterus. So over time, if Jackie's taking estradiol, and I would hope, she would be taking progesterone. So I'm going to go back to that because progesterone she would be a great candidate for progesterone. Yeah. But the estradiol would cause some thickening of that endometrial lining. If she's got fibroids, probably exacerbate her fibroids, and she'd have some probably cramping, some irregular bleeding, some spotting, heavy periods. Over time, that would probably happen with her. But I would definitely say in terms of perimenopause, that's where the progesterone really comes in.
Yeah. And we talked about this, I believe now it was, I don't remember the number. It was when we talked about fibroids not fibroids, early menopause or premature ovarian insufficiency. The woman on that episode, I believe she was also like in her late 30s. And we were sort of talking something similar. She went on a little estrogen. She felt great, right? In this context, I just don't, like you and I would not prescribe bias necessarily for a woman in this situation.
Or estradiol, yeah. Biased is a combination of estriol with estradiol. I would say probably, number one would be, okay, she's 39. Let's check her hormones. Let's see, where her estrogen levels are, where that follicle stimulating hormone is, where that luteinizing hormone is, even, checking her progesterone and checking some of the other hormones too, because this is something that we get a lot of questions about. And I understand there's so much information about hormones and how amazing it could be. But here she is saying, I want to take something that's going to make me stay youthful, lose weight, help my hair, help my bones, help my libido. That's a lot to ask from one thing.
That sounds like a panacea. That doesn't really, hormones are amazing, but they don't necessarily just fix all those things when you start taking them.
Be awesome if, you could take one thing or put on a little bit of some estrogen cream and all of a sudden all that is better. It really is, when we work with a client or a patient, it's about taking the whole view in, not just the estrogen and progesterone or where they are in perimenopause or menopause. Also, we look at the thyroid hormones, we look at the adrenal hormones, we look at those androgens like the testosterone and the DHEA, the pregnenolone. So kind of pulling all of that together and coming up with a treatment plan that might not just be one thing, but it might be a collection of few things, plus some supplementation, plus some lifestyle changes that we could do on here. So I wish the estriol would like you said, be the panacea for Jackie here, but it probably wouldn't.
She's probably, if she's almost 40, so she's 39 as of this question, which we received in the early part of July. So she's not quite 40 yet. She's got probably another good 10 years before she's a true estrogen candidate. As menopause, usually occurs in the, 50 to 51 range. Now you mentioned a few things there. So thyroid, progesterone for sure. She's definitely gonna be a candidate for progesterone. It may have an impact on some of those things she's looking for. Maybe her hair, it should not cause any weight gain. Although those hormones, because they are steroid hormones, all the sex hormones are steroid hormones. They can cause some water retention, so it's something to consider. But usually with progesterone, it's 95% of the time, it's usually pretty well tolerated.
Yeah, I would say I have a few patients I can think of in the last 20 years that couldn't tolerate progesterone because of the water weight or the weight gain or even the puffiness. But that usually your body gets over that, or you have to adjust depending on the person.
Yeah.
So I would say for Jackie, progesterone can be amazing for hair. It's like the unsung hero for hair. So adding in some progesterone may be helpful for her hair, because she's saying after pregnancy she's lost a lot of hair, which is really common after pregnancy, postpartum. But usually then the baby hairs come in and things seem to balance out once they may not be nursing or that prolactin has gone down, because right after pregnancy, that prolactin goes up to help with lactation. But if the prolactin's up, when you do someone's blood work that has high prolactin right after having a baby, which is natural, is you'll see the FSH and LH, which are the signals from the brain monitoring the overall health of the ovaries, are perfect. They're like at a 5, 2.5, 4.5. The LH and FSH are perfect. It's showing that that ovarian health is good, but you'll see the estrogen and progesterone are non-existent, because that prolactin keeps that, because that's nature's way of trying to prevent ovulation, so you don't have a baby right after another baby, which has happened before. So that's why a lot of times I'll have a lot of that hair loss. But then once they start to get their cycles back, depending on the woman, some females I've had them get their cycles after pregnancy in a couple of months, and other women 18 months, a couple of years. So it all depends on the person. But once those hormones start to come back up, the hair does start to grow in. So I'm thinking with Jackie, maybe since her pregnancy, maybe her hormones haven't come up, maybe the progesterone hasn't come up, or she might be making more androgens like the testosterone and the DHEA that could be creating more of like an androgen-derived hair thinning or hair loss.
Yeah, sure. No, when you're pregnant, you got to realize too that a woman's estrogen, progesterone when you're pregnant the numbers are just off the chart.
Oh, yeah.
I mean, just literally off the chart. I mean, what does it go up to like, progesterone's like 4,000, estrogen's, in the 4,000 range, where on a normal cycle, you might see a woman's estradiol level, at maybe a couple of hundred, maybe 200 or 300. And you have the baby and those hormones basically just disappear. So you go from having for 9 months this tremendous amount of hormone to no hormone whatsoever, not to mention the stress of a newborn. So of course, like I said, a little bit of extra shedding and the thinning part, I don't know if shedding and thinning is sort of if she means that as being the same thing. But I know we talked about one of the last episodes as well, like the volume of the hair starts to change. So, maybe maybe she is experiencing some of those perimenopausal symptoms, but, technically, she's not really a candidate for estrogen quite yet.
I don't think she would feel very good if she took a biased, that combination of the estradiol and the estriol, or just a straight estradiol. I think she would feel really bad on that. I think she'd feel really good with the progesterone. Checking those adrenal hormones would be a great idea. Like she was saying about, getting the libido back. Estrogen is an amazing hormone, but too much of a good thing is not a good thing. You have too much estrogen in the system, and she's like a runaway train. She will just knock everybody down. So in some ways, having that progesterone around helps buffer the estrogen. It also helps buffer the androgens. So I would say she would be a great candidate for doing the progesterone, but it's interesting. There's so much information. Like I was just playing around with Google a little bit about, giving perimenopausal women estradiol.
Yeah, right. So for you, all you ladies out there that are listening, you do have to be a little careful and kind of check and double check your sources and see where the information is coming from, because from our standpoint, a woman that's 39 years old is not a candidate. Now, we talked about, so some things she could be a candidate for, potentially. You said progesterone, possibly estriol as either as a face kind of moisturizer, anti-wrinkle cream. That usually should not be a problem. Possibly vaginally if she's having any, pain with intercourse or something like that. Depending on how recently she had the baby, that might not be appropriate quite yet. So some localized estriol could potentially be possible, but even still, if she's applying it vaginally, that still could cause some issues if she's cycling on her own.
And then maybe, pregnancy is, like when you think about actually pregnancy, it's so amazing, like what happens, what this female's body goes through. It's incredible. So, pregnancy can cause interesting things to happen to the thyroid, because we both work with a lot of thyroid patients, and I'll say, when they get pregnant, the thyroid could stay the same after pregnancy. It could go really high, it could go really low. Hashimoto's could crop up. Your Hashimoto's can go away. I've seen Hashimoto's go away after pregnancy. Yep. It's amazing what pregnancy can do for the body.
It literally goes in any direction.
It's like a gremlin, just whatever it wants to do.
Yeah, and you can't predict some of those things. It just happens, and there's no real for some reason pregnancy. The body does a really good job of protecting a woman while she's pregnant, right? Not a lot of things happen during pregnancy, besides maybe some, typical
anemia or something.
Complications. But for the most part, and it would make sense from a survival standpoint that your body would do the right thing by protecting you. But once the baby's, you've given birth and the baby's out, anything can happen from an immune system perspective at that point.
So I would say for Jackie, especially all the patients that I have that once they have the baby, I usually say wait about 6 to 8 weeks after the baby, because the body has to heal, is check her thyroid. Some of that, some of the things she's talking about here about wanting to lose weight and her hair is thinning pretty badly. A lot of times I've seen when that thyroid tanks down, that causes a lot of thinning and a lot of shedding, that it really wasn't postpartum. It was just that thyroid decided it wanted to, go on vacation.
Yeah, right. Now, she mentions libido. Of course, that for everyone that always conjures up testosterone. In this case, she's a candidate. She could be a candidate for testosterone, but because of the hair thinning, she'd probably want to be a little careful with that.
Yeah, because testosterone can exacerbate hair thinning. I mean, I have some women that take tons of testosterone and they have so much hair, it's unbelievable. And then other women, you give them a little bit of testosterone and they start shedding a lot like crazy, especially in the temples and the top. So that would be something to test her hormones, see where her testosterone level is at, and then decide how you want to work with that. I would say for her, definitely building a base of progesterone first,
Yep.
and then doing kind of the accoutrements, or like, as I call it, the frosting on the cake,
Yeah,
build
right.
that base first.
Testosterone, we always like to be very conservative, start very low, establishing what you call sort of your androgen tolerance, and then sort of gradually building up. So, the things you have to pay attention to if you're using testosterone, you got to look for breakouts or blemishes in the short term, hair growth, shortly thereafter, if you continue. So on the chin, where else? Upper lip, or maybe around the areola, abdomen, below the belly button. And if you kept going, then you might actually experience some hair loss, which usually it never gets to that point because everyone's concerned about the previous two.
You just kind of keep a balance on it, or just keep your checks and balances on
so
that.
then the dose can kind of gradually increase. You might not notice too much of an impact on a lower dose, but then as it goes up over time, but some women can tolerate hardly none or actually none because their skin just flares up right away. And some, like you said, can handle quite a bit on the testosterone side. So every woman's just a little different.
So that might be something, considering for Jackie, just because I think of testosterone more of as an adrenal hormone. For you as a male, testosterone is a reproductive hormone because you have the doohickeys and the gadgets to produce that, Whereas females, we make a little bit from our ovaries, but we make the majority of our testosterone from the conversion of DHEA, which is produced in the adrenals, that travels in the peripheral tissues and converts to testosterone. So when you see somebody that might be under a lot of stress, their DHEA, the adrenals are kind of diving, or with age, you'll see that testosterone level go down. So when I especially have a younger female, in their 30s and their testosterone is super low, I'm either like, okay, what's going on? Are you not sleeping? Are you really stressed?
If she's got a newborn, her hair's thinning, her libido's low. So as stress level goes up, all those things start to go down. Very often especially for, the busy moms that we see, we test their DHA and testosterone, and both of those numbers, one or both of them will be low. Mm-hmm. Like you'll see a testosterone, it'll say less than 3. Like they have literally none, or at least it'll be in the single digits. It'll be less than 10. And usually, what would you say an average for a, healthy, hormonally balanced woman, approaching her 40s, what would you say an average testosterone is?
An average testosterone would probably be right around the mid-20s. I think the mid-20s. Yeah. Now, if you look at the reference ranges, if you get your blood drawn and you have your total testosterone taken, and you're looking at the reference ranges on, these labs, they'll have Quest is 2 to 45, and LabCorp is 7 to 55. It's just giant. Somebody can be at 7 and that's a normal testosterone, but they can also be at 50 and that's normal. It's such a wide expansion there that does really kind of depend on the patient. So if I've had a patient that maybe they were more athletic, more driven, maybe they seem like they had more testosterone when they were younger, they might be ones where if you had tested them in their early 20s, their testosterone ran around 40. And then there's other women where, like you said, you give them a little bit of testosterone and they instantly break out. Maybe their natural level is closer to 18 to 23. Right. So it kind of depends on the person, because the body is so smart. You don't want to bully the body. You don't want to just take all this, do what it will rebel at some point.
Sure.
So it's just about being gentle and guiding the body in the right direction that we want it to, so that we can look at long-term goals, like she's talking about bone density and that kind of thing. And then also looking at our short-term goals, which is, having a libido, especially after having a baby.
Sure. So this one's actually about estrogen and perimenopause, not testosterone and perimenopause, but she mentioned libido. Of course, that always comes up. It doesn't, if the stress level is high, testosterone is not going to usually fix that. Like you said, testosterone is sort of like the icing on the cake. When the other, you have a good foundation. If it's a menopausal woman, certainly estrogen, progesterone first, possibly testosterone later. It doesn't
then build off.
Yeah, then build off of that. So, but the main question is she really a candidate for estrogen? So it's kind of like yes and no, right? So systemically, she's not a candidate for estrogen, but locally, face and vaginal areas, if needed be, she potentially could be.
But for the estriol.
Just for the estriol,
the E3. You would never want to put with a female that has a uterus estradiol on the vaginal tissues, especially if she's perimenopausal. So I think the point about this podcast is, there's so much information out there, especially for women. I mean, I'm 51, but I've worked with women for a long time. I know what it's like to feel tired and, to feel like you're gaining weight so fast and it's so easy and not feel good. And then you go and look online and there's so much information saying that perimenopausal women are candidates for estradiol. And then I'm just pointing to the estrogen, which I get. Estrogen is amazing. It's what makes us female. but it might not be the one thing that, somebody like Jackie or a perimenopausal female needs. Maybe that is the last thing she needs. We need to work on some other things.
Well, it's not that it's the last thing that she needs, but she just might not be able to tolerate it from a bleeding perspective, because eventually that probably would. Now, in a case like this, this is the thing too. She's talking about taking estrogen cream. She doesn't mention anything about progesterone. So in this context, the number one rule of hormone replacement, and that we never break, is you cannot take estrogen therapy without progesterone, right? We're going to do another episode in a short bit talking about why progesterone and the type of progesterone, why that's necessary. She cannot just take estrogen cream or some form of estrogen without balancing it with the progesterone.
Yeah, absolutely. And we'll definitely go into that because there's, sure, if somebody doesn't have a uterus, old school theory is, you can give them progesterone, it's fine because they don't have a uterus. But I feel like even my menopausal females that have hysterectomies, they don't have a uterus, we still want to balance, because progesterone's important. It's not just for the uterus. There's so many things. It's great for sleep. It's great for mood. Like I said, it's kind of the unsung hero for hair. There's so many things that progesterone is good for, but I guess maybe to really make it complicated, I do think doing some blood work and checking levels is important.
Yeah, sure. Oh, yeah.
Yeah, so I would say
we do blood work all the time.
Symptoms and blood work, I think or some kind of objective data to say, where are your levels of progesterone? Where are your levels of estrogen? Because, for Jackie or any other perimenopausal female, when you check their follicle stimulating hormone, that was just checking if they are going into menopause, they might, still be at like a 10 or a 12. It's still, then you would say, that is not a person that's a candidate for estrogen, like when their FSH would be closer to like 60. Then you'd say, yeah, that person could be a candidate.
Right. So, like I said, just be careful of what you're reading online. If you're in your, late 30s to your later 40s, you're technically not a candidate for estrogen therapy, regardless of what Google says, because we would, in a case like this, like, Jackie's situation, we would just say, sorry, you just can't. We just can't prescribe it yet. Now some of the episode we did previously about premature ovarian insufficiency, if it was truly that, which is a very rare problem.
I think they call it now primary ovarian insufficiency.
Yeah. That doesn't happen very often. So just because you're having some of those menopausal symptoms does not mean you're in any type of, POI, as they call it. Now if you were, then yes, you're potentially a candidate. But if you're having a consistent cycle every month, you're not. That's really the distinction. Having a regular cycle every month makes you sort of not a candidate.
Yeah, because if you add that estrogen to it, I remember you had a patient not that long ago that was technically, still cycling and then taking, I think from another practitioner, some estrogen, and, that then the periods are all over the place. You're chronically spotting, it's all over the place.
So she was on, so we did sort of like a one-off consult because she was seeing another practitioner, but was having a hard time because she was bleeding a lot. And I believe she was 50 or 51, something like that.
No, she's in her 40s.
Okay. All right.
It was like 48.
Okay, 48. Okay. I don't remember all the numbers, all the ages run together. So, okay, so 48, and she was having like 2 periods a month. And we are talking about it, and I'm trying to figure it out. And then I asked the question sort of, haphazardly, which should have been my first question. I just assumed some things that I, didn't even think to ask, but her period actually never stopped. Right. So she just went from having her normal period into rhythmic dosing from another doctor. And I'm like, wait a minute, your period never stopped? She goes, oh no, I just kept on going. I said, well, that means that you're not a candidate. You cannot be doing rhythmic dosing if your own period is still intact. And she was having literally like a period every 2 weeks, which is what will happen if you're using estrogen. When you're producing your own, you'll just start bleeding more often. So lo and behold, of course, she stopped the rhythmic dosing. Now, she felt good because of the estrogen, right? Because that's what makes a woman a woman. But the bleeding was just, sort of uncontrolled. It was like almost all month long. She stopped using the estrogen cream and the bleeding went away. Because she was not a candidate for it. So someone started her, and I've seen that issue, especially with rhythmic dosing. They're in perimenopause, they're towards the end, but their cycle is still relatively consistent, and they were put on a rhythmic dosing. You can't really do that. It just can't be done. So now rhythmic dosing, we'll talk about that on another episode later. That that's a totally different type of hormone dosing protocol that intentionally creates a period. So that's a little bit of an extreme example. But if you're already having your own period, it sort of complicates things, and it's just not really a viable option for most women. So. That stuff does happen. So just be careful. If you're, like I said, in your 40s, you're probably not a candidate, no matter what anybody tells you.
Or if you have a question, just like, the questions we do for the podcast is just go to our website, progressyourhealth.com. We have a little tab called Ask the Doctor and put in your question. And we always change everybody's name. So we called her Jackie, but I'm sure Jackie knows who she really is when she listens.
Or this is on YouTube. You're watching the video. For those of you that are on audio, I'm sorry, but if you're on YouTube and you're watching the video, down below in the comments, just if you feel comfortable, right? You have your username on there, so you might not feel, super, there might not be as much privacy there. That's why we're giving people the access on the website to be able to ask those questions.
We love all the information. I know on those comments you might not be able to put a whole diatribe, but we love it. The more, if you are taking some hormones, you have some questions, you have some blood work, put in all the detail, because, a lot of times, we're talking about real people. Somebody like Jackie, there's so many other Jackies out there. So when you get a lot more information, then we're actually talking about a real subject rather than, I have hot flashes. How do I get rid of them?
Yeah,
it's like, if you're having hot flashes, you're probably having trouble sleeping, which is going to make you tired, which is going to make you gain weight, which is, there's so many things when it comes to the human. It's not like one thing.
Yeah. Well, and it's really interesting too, to see the questions that people are asking, because it's just it's a way to have your finger on the pulse of how HRT in general, like where things are going, where the trends are going, what are women experiencing, where are their challenges. And that's really why we're here doing the podcast. So if you gotten some value, if we are able to answer a question for you, feel free to like and subscribe on the channel. We're trying to grow our audience as much as we can. Anything else to add about Jackie, or we can wrap this one up?
I think this was great. Thank you.
Okay. Until next time, I'm Dr. Mackey.
And I'm Dr. Davidson.
Take care. Bye-bye.